Yes, primitive round spindle cell with differentiated rhabdomyoblast and desmin and myogenin positivity. Now the alveolar rhabdomyosarcoma, it is second most common of rhabdomyosarcoma. It comprises 25% of the cases. Here we can see the monomorphic population of primitive round cells with skeletal muscle differentiation. This tumor is highly aggressive, rapidly growing, often diagnosed with distant metastasis. Age group is, as I already said, 10 to 25 years of age. Whenever you see this monomorphic population of primitive round cell, you can think of this alveolar rhabdomyosarcoma. Site of the alveolar rhabdomyosarcoma will be deep soft tissue of extremities mostly. Also occurs in head and neck, paraspinal and perineum. Symptoms depend upon the location of the lesion. Gross, all the rhabdomyosarcoma are soft, fleshy, gray. You can see necrosis, hemorrhage also. And it is a highly cellular primitive round cell with a scant cytoplasm and hyperchromatic nuclei. Sometimes it are arranged in nests separated by fibrous septa with loss of cellular cohesion. I think morphologically nobody can, if somebody is reporting, nobody can miss this alveolar rhabdomyosarcoma. These are the microscopic features. See, these are all tumor cells. Here also this single line of this tumor cell around the vessels. This is the compact one. There is a loss of cohesion of this tumor cell here. This is desmin positivity, dense, diffuse. So, in essential and desirable diagnostic criteria, how we will approach whenever we will think of it. Whenever you see this uniform primitive round cell in a tumor of young age of extremities, and this uniform primitive round cell, you can, and with alveolar growth pattern, you can think of alveolar rhabdomyosarcoma supported by myosine positivity and desmin positivity. I think postgraduate students should concentrate on this part, because this is the gist of this topic. How you will think of this. This is the minimum criteria to label as alveolar rhabdomyosarcoma. Now the pleomorphic rhabdomyosarcoma. It occurs in older age group, 6 to 7 decades. It also high grade, and it generally in the lower extremities and rapidly growing. It is also a fast growing tumor. As Dr. Mandal has said, history is very important, very, very important. I do in our college. Whenever they want to show me a slide, I ask first I ask the requisition slip, what they have written. From requisition slip, you can lead the diagnosis, and you can know from what investigation you can want, or you can talk to the clinician or radiologist. You must see the requisition slip, and then you proceed. Gross, large, well marginated, white, fleshy. Microscopy, it is, as the name suggests, pleomorphic. The large atypical multinucleated polygonal spindle rhabdoid cell with snowflake cytoplasm. Very pleomorphic appearance, this pleomorphic rhabdomyosarcoma. Desmin positivity, myosine is low. This is the essential and diagnostic desirable criteria. Pleomorphic cell with copious brightly snowflake cytoplasm. Pleomorphic cell you can see in the malignant fibrous histiocytoma. But here you can see this brightly snowflake cytoplasm. So you can think of this pleomorphic rhabdomyosarcoma with desmin and myosin positivity. This is the gross. This is the gross. You see this fleshy whitish with areas of this necrosis. This is a huge tumor. Grossing is very important. All reporting histopathologists must gross himself, or actually in the medical colleges must see the tissue, the bigger tissue, because sometimes the postgraduate, first year, second year postgraduate, they miss the section from the area they should be taken. Or at least you have seen the gross, you can expect the finding, अरे ये तो malignant होना चाहिए था. How come this only shows necrosis or hemorrhage? This is the microscopic picture. See this bizarre cell with macronucleoli. Here, these are the giant cells. I think one cell is cannibalizing another cell here. You can see in this pleomorphic rhabdomyosarcoma. Atypical cells, atypical mitosis also. Desmin is positive, myosin is focally positive. Now, as I think Srikant has labeled this one, or Dr. Mondal has shown this sclerosing rhabdomyosarcoma, the new entity. Here is this spindlo-sclerosing rhabdomyosarcoma. It is 3 to 10% of the rhabdomyosarcoma. It occurs in both child and adult, both age group. Rapidly growing painless tumor. Sometimes it occurs congenital, sometimes it is found in intraosseous. You can see inside the bone also. Site is head and neck and extremities. So this can be small, this can be small to large, white to 10 with a whorled appearance, necrosis and cystic area. All generally a big tumor or sarcoma, carcinoma, you can see the necrosis or cystic area. Microscopic finding, cellular fascicle of spindle cell. Intersecting pattern, this is the most catchy thing. If you are seeing a spindle cell neoplasm and you see cellular fascicle of spindle cell with intersecting pattern, you can think of this tumor, spindlo-sclerosing rhabdomyosarcoma, with blunted ovoid fusiform nuclei, pale snowflake cytoplasm, tadpole cells, and prominent hyalinization or sclerosis. That's why it is called sclerosing rhabdomyosarcoma. Desmin is markedly positive in this case, and essential and desirable criteria of this sclerosing rhabdomyosarcoma is cellular spindle cell fascicles in a variable sclerotic background with desmin and myosin positivity. See this gross sclerosing rhabdomyosarcoma, solid, these capsules, and these are the cells, these are the tumor cell, and see this marked hyalinization of the stroma, spindeloid cell with marked hyalinization, where you can see the perivascular arrangement. This is the another slide. You can see this spindle sepet closely packed, very cellular, and this desmin positivity. See this desmin positivity in cellular pattern. This is, I think, H3K20Me2 positivity to differentiate it from malignant peripheral nerve sheath tumor. It will lack in this it will positive in this sclerosing rhabdomyosarcoma. Now this photograph. Now we are doing working as a diagnostic pathology, but other than diagnostic pathology, we can also do the preventive pathology, because most have in these government medical colleges, when you see a patient comes, most of the, I think 50% of the patient comes from the periphery in advanced stage, very advanced stage. And I particularly ask, क्या करा रहे थे इतना लेट आए, होम्योपैथी में थे क्या? Most of the time they say yes, they are from the periphery, from the village. गिल्टी हो गया, होम्योपैथ का फलाना बाबू हैं, गिल्टी से उसको दबा देंगे, वो गिल्टी दबाते दबाते वो कुछ दिन साइकोलॉजिकल लगता है कि कुछ दबा, फिर काम में लग गया, फिर 6 महीना बाद आया ह्यूज ट्यूमर. यू कैन नॉट इमेजिन द ह्यूज ट्यूमर वी आर फेसिंग वेयर द कमिंग टू आवर हॉस्पिटल. सो what we doing, we can do, because diagnostic many people are doing, but preventive oncology, other than clinician, no pathologist is doing. So we started as our 81 batch, and we involve our young previous and existing postgraduates. We did a last year on the Cancer Awareness Day, we did a cancer awareness program in Pawapuri Medical College. So this is the road trip we started. This is Dr. Bariyar, he was then head of the department. This is my batchmate, Rajiv. This is also Rajiv, and these are the pathology. These are the just past PGs. Now Alok is here, OP, Shyam, Mishra. No, this is Chandra Mohan, this is Shyam. Always I say, tum log jodwa bhai ho. And this is Dilip also. Just saying कि we should take out time, some preventive or social thing, go to the villages like Tata Memorial, Mujapur. They are doing some awareness program. They are going to the villages. They are picking the case from there for oncology. I have recently seen a report in Times of India. They have picked, I think, some 1,000 cases of oral cancer from the village by screening only. This is the picture of November 7 last year. This is the PowerPoint, their principal Sahib, Chaudhary ji. This is my batchmate, the head of the Department of Orthopedics, Narendra. See, the patients are so interested on these programs. They listen and they say कि कोई हम लोग को बताया नहीं कि कैंसर क्या होता है, कब हमको जाना चाहिए. Must start some preventive oncology also. Alok is distributing some leaflets. These are the now the peripheral nerve neoplasm. Just for briefing, because for nerve histology, many pathologists don't know where the Schwann cell, where are they from Schwann cell. So see, this is the Schwann cell. This is a motor neuron, and this is in the central nervous system. This is the peripheral nervous system, and this is the Schwann cell. Here it is Schwann cell. When you see schwannoma, you must think, okay, this cell is making the schwannoma. And the cross section of this nerve fiber. This is the bundle of nerve fibers. There is a perineurium here. When you say perineurium, अरे भाई perineural cell कहाँ होता है? We don't know where. You must know the location of the normal histology. Okay, it is arising from the hair, from these nerve bundles. The perineural cell is there. So this is tumor of perineural cell. This is the just for briefing this histology. Peripheral nerve neoplasm. Schwannoma. It is a benign nerve sheath tumor, differentiated neoplastic Schwann cells, slow growing, asymptomatic, incidental, and 90% solitary. It is most of the time incidental finding or solitary, and it is a benign. It will peripheral nerve under the skin or subcutaneous tissue, head and neck, extremities, and it also occurs in the spinal intradural location. Gross. It is a benign tumor, and the gross is very much benign. When you see globoid smooth surface less than 10 centimeter, in microscopy you Schwann cell well differentiated, or I think it is not a problem or diagnosis of schwannoma, compact area A, Antony A,